What's up, guys? It's the PA Professor. Today we're back with another video. Today we're going to be covering a super high yield topic. This is a video on atrial fibrillation, aka AFib. This is super high yield. You need to know this. Please pay attention and let's go. First off, like I always say, if you don't know anything about a disease process, take the words, interpret it, and break it down. Atrial, meaning pertaining to the atria of the heart. Fibrillation means quivering, right? So you have a quivering of the atria in the heart. And you have this quivering because you have this abnormal heart rhythm going on, and it's due to multiple ectopic sites firing within that atria. Let's look down here right quick and go over the normal physiology of the heart. So you usually have the SA node, which is the pacemaker of the heart, and it has something called automaticity, and this automaticity is basically, this means it automatically has a heartbeat. It automatically can come up with a heartbeat and cause the heart to contract. So usually what happens is the SA node takes that automaticity, creates a heartbeat, it goes to the AV node, blah, 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 all the way down, bundle His, bundle branches, Purkinje fibers, and that's what causes your heart to contract, right? But what's happening here is, for some reason, not just the SA node has automaticity, but these cells somewhere along the wall of the atria have gained this automaticity, usually due to fibrosis, stretching, injury. And so also what can happen is, well, let me start with this. Those ectopic sites gain automaticity and they just start beating uncontrollably. And this is what causes like your palpitations, weird feeling of like chest pain, chest pressure, just a weird feeling in your chest. This is what is going on. These ectopic sites are just firing, and it's causing this atria to just quiver instead of a normal atrial contraction with the SA node automaticity. It's just quivering because it's got all these sites trying to start a heartbeat. And what happens when your atria just quivers? It can't contract all the way, thus no sufficient amount of blood gets to the ventricles, and then, your cardiac output diminishes. Also, what can happen is, since you have some stagnant blood in here, since you can't pump it all out, you start forming these blood clots. And then last point here is AFib is the most common cardiac arrhythmia. You will see this on your test. I had questions on this on Rosh. And you'll see AFib. It's super common in real life, so you'll see this in your clinical practice as well. But you need to know this definition, and then you need to know the results because of this, like kind of the patho. Etiology, what causes AFib? Like I said, this atria can stretch and gain automaticity is the way I think about it, at least. And what causes your heart to stretch? Well, overload and fluid. Heart failure can cause overload and fluid. You can have some structural, like congenital heart problems that can later on in life cause AFib. This is lower yield than this. Then you can have heart disease or coronary artery disease that if you have an MI and it kills some part of your atria and it's fibrotic and it gains automaticity, boom, you can end up with AFib. So really, coronary artery disease, heart failure, these are your more high yield. This in general, the etiology of AFib, not super high yield. You just want to be able to kind of confirm AFib from an EKG and treat it. But I would have just a decent understanding of what causes it. Symptoms, so we talked about you have multiple ectopic sites firing, which is trying to create multiple heartbeats. So that's where this palpitations comes in, right? And then the decreased cardiac output because you're only quivering the atria. That's where these symptoms come in. Pre-syncope. You're almost passing out because your heart can't meet the demands of the body, and dizziness as well. So these are high yield. The vignette will have one of these three. Here's where your moneymaker is, I guess I would say. This is in bold, red, underlined, and 3-starred. You need to know this. If you take anything out of this video, it's probably this. So the patient walks in, they're having palpitations, right? What do you want to do? You want to get an EKG. This is your best initial test. If the boards ask you what's your best initial test on someone coming in with palpitations or chest pain, for that matter, it's EKG. What will you see if it's AFib? You'll see an irregular rhythm. Take that to the bank. You're going to see this at some point on your boards, 100%. So what does this mean? It means if you look at the QRS, right, we should be able to read EKGs pretty good by now. If you look at the R to R interval, you see that it's super random, right? It's just that's longer than that, that's longer than that. It's just random. And then you have no P waves because the SA node's not firing alone like it was. You're having all these quivering ectopic sites, which is creating these just quiver lines, right? This is what's called an irregular rhythm. There's no pattern to it. It's not sinus. Take that to the bank. You're going to see that. And then I described the no P waves because you have multiple ectopic sites firing. Usually the P wave represents what on an EKG? Atrial contraction from the SA node, right? So if you don't have that and you have ectopic sites firing, then you don't have a real P wave. You just have these quiver lines. So the boards may ask you, so you did an EKG, you confirmed AFib, what's the next best test? That would be this echo, specifically a transesophageal echo. And that is, you want to see if there's a blood clot in the atria. We talked about blood clots forming and these patients being susceptible to strokes and blood clots. Well, this would be your test to see that, the TEE. If the answer choices are transesophageal echo or transabdominal, it's TEE because the T can see. The TEE can see best. The transabdominal echo is just not as specific as the TEE. So you confirm someone with AFib. How do you want to treat it? Let's start in an ER standpoint, acute. This person comes in with palpitations. They're tachy at 101. They have an irregular rhythm. So you want to first initiate, for board purposes, a beta blocker, more than likely. But know that you can use a non-dihydrocalcium channel blocker. In my rotations in the ER, my doctor would use a diltiazem drip, which is a non-D calcium channel blocker. But for boards, I think majority of times I saw metoprolol as the answer. That's your answer. You want to control rate first. And there are some instances in real life where instead of using like medications, you can use like a synchronized cardioversion, stuff like that. But for board purposes, 95% of the time, it's going to be rate control with this beta blocker. In real life, like I was saying, if they're unstable, like their BP's dropping super bad, you can synchronize cardiovert them. But then you get into this weird field of like anticoagulant. Do they need an anticoagulant beforehand? How long have they been in AFib? How at risk they are? So this is for board purposes. Just know you have to control the rate. In chronic management of AFib, same thing. First, you're going to want to take control of their rate. And if that doesn't work, then you want to add on a rhythm control medication like amiodarone. This amiodarone, remember, it's like a sodium, potassium, and every other channel blocker, so it kind of controls those ectopic sites from firing. And then also, we talked about these patients are more at risk for stroke because they have stagnant blood in their atria. So scientists, I guess, or doctors have come up with this score, CHADS-VAS. This CHADS-VAS score is a score to determine the risk of AFib patients for having a stroke in the future. And each one of these letters stand for like a condition. Like C is congestive heart failure, hypertension, age, I think it's over 75, diabetes, a past stroke, you get 2 points. Any vascular disorders, clotting disorders, age again, and then sex is another one. And this determines whether you are at risk of having a stroke with AFib. If you have a score of 2 or greater, it says that you should probably be put on an anticoagulant. So what anticoagulant do we use? Well, these NOACs like Eliquis, Xarelto, these two are very, very, very high yield on the boards, but so is our old friend warfarin or Coumadin. Also, you need to know these generic names. The PANCE will have generic names. I can't remember if it had brand names, but I would remember generic if anything. And that's when you would initiate anticoagulation if the if the CHA2DS2-VASc score is 2 or greater. Also, warfarin is not a NOAC. I don't know why I put it there, but you can use warfarin as an anticoagulant. So with that being said, let's go over a high-yield vignette question. A 62-year-old female presents to the emergency department with palpitations for 6 hours prior to arrival. Her past medical history is significant for one MI 2 years ago. On physical exam, you notice an irregular heartbeat. Okay. An EKG is performed where it shows an irregular rhythm with no discernible P waves. So right there, you should know this is AFib just by this sentence right here. An EKG is performed where it shows an irregular rhythm with no discernible P waves. Vitals are 150/90 and heart rate is 114. So overall, she's pretty stable, right? If she wasn't stable, her BP would be tanked low or tanked high, right? Her heart rate 114, she's 14 over the normal. So she's tacky but not super tacky. So she is stable. So it asks what medication should be initiated. Well, what do we want to do? We said we wanted to get control of her rate, right? So your answer is you want to initiate a beta blocker or a non-dihydropyridine calcium channel blocker. Guys, that is AFib. I really highly encourage you guys to learn the information that was provided on this little video. It is high yield. You will get a few questions on AFib on your boards. Again, good luck on all your PANCE, EOREs, EOCs. You'll do great, and we will see you guys in the next video. Thanks for watching.